Good morning. I want to express my appreciation to the Coalition for Global Hepatitis Elimination and to the Task Force for Global Health to invite me to this webinar on hepatitis C. I will be talking about scaling up HCV testing for elimination in Mexico. I would like to start by mentioning how was the situation before 2018, up to 2018. You can see in this slide that when we screened blood bank samples, we screened almost 2,720,000 people, of which were accepted for evaluation approximately 1,800,000, and the prevalence of antibodies to HCV was 0.5%. I took one of these studies in the general population, and as you can see in this slide, which included 71,322 individuals in the general population, the prevalence of anti-HCV antibodies was 0.5%, and when we studied their viral load, that decreased to 0.3%. So the previous situation in Mexico is that we estimated a viremic prevalence in the population of 0.4% with an estimated number of infected persons of approximately 550,000 people. Up to 2018, we were able only to treat approximately 6,000 people in all the years previous to 2019, and I will show you later on how this compares to the data we have at present time. We decided that we needed to facilitate the diagnosis and we need to increase the awareness, which is essential for screening and early detection, and also to allow the identification of patients at risk. And this is very important when we consider the possibility of installing an elimination program throughout the country. We also then decided how to facilitate the diagnosis, and we decided to use point-of-care testing because this gives us easy access to rapid diagnostic at the point of care, and it also allows, obviously, the testing and the results to be obtained in the same visit. Therefore, patients do not have to be coming back to do their testing. I will show you later on that at the same time that we do the point-of-care testing, we take a sample for the possibility of having to check the viral load. The other advantage of the point-of-care testing is it can be done outside the clinical laboratory, and it can also be interpreted by non-specialists. And this point of non-specialist is very important because when we designed the National Plan for Elimination of Hepatitis C, which we began to do in 2019 and implemented in 2020, our aim was to identify and treat approximately 20,000 patients with hepatitis C in 2020 and increase it to 40,000 yearly for the next 10 years. So at the beginning in this year, in 2020, we tried to identify the patients with viremic hepatitis C in particular settings. For example, our goal is to eliminate hepatitis C in this year in co-infected patients with HIV and to facilitate the access to treatment for those patients that are being detected in the blood banks. And for that, it's very important to have the help of the primary care physicians because Mexico is a huge country and it's very heterogeneous, and we need the help of the primary care physician for screening and also for treatment. You can see here that we have approximately 300,000 primary care physicians in the country that could help to this purpose. So our aim was also to train the primary care physician and to have a consistent supervision of them, having a linkage between the different health systems in the country. And I think this is very important to consider not only the screening, but also who is responsible for doing the screening and who is responsible to implement the treatment, which I will be showing you later on. We then negotiated a combo with the government and the industry, which includes point-of-care testing, the viremic confirmation with the viral load, ALT, platelet count, creatinine, and antigen of hepatitis B. And we also have the help of 125 specialized nurses that go to specific sites, for example, when we screen prisoners or if we're doing in addict clinics, etc. And we have an education program for general physician. And most importantly, we designed the national registry, which I will be showing to you in a few moments. I would like to say that this combo is free of cost for every individual in Mexico. So this is a program with equity, so everyone can access without the cost to the testing and to the treatment. And I would like to spend a few moments to tell you about the platform that we designed. And we built a Mexican observatory with the aim of being able to have the hepatitis C elimination program by 2030. Let me go through the platform, which you can see in the left side of this slide. Once a patient comes in for screening, we advise him of the program, we obtain verbal authorization for possible testing, and once the patient accepts, we proceed with the screening. If the screening is negative with the point of care testing, then the process is finished. If by doing the point of care testing, which we get the results in a few moments, then the patient signs an informed consent, so we can put his data, his demographic data of identification and contact into the platform. Once we put this into the platform, and this is very important because the patient will be followed up through the whole process of treatment. Then we investigate risk behaviors. I put an examples here of pregnancy, transplant, HIV, and all the other risk behaviors that we know. And we request for the patients to have an appointment in the institution of care in 2 weeks. The reason why we decided in 2 weeks is because approximately for obtaining the results of the test, it takes 7 days to the whole country to get the result. So we want to make sure that we don't have any problem and the appointment is given to the patient in 2 weeks. But the important thing is the appointment is given in the moment that we register the patient. Before we have the result of the viral load, he already has an appointment with the physician. We then generate a label for future sampling. So we were able to, we are going to be able to follow up not only the results of the testing at the entrance to the study, but also 3 months later and 3 months later to get the sustained viral response. If the patient has liver cirrhosis, he is then referred to a specialized unit, and if not, he is being followed by his primary care physician, and we get the automatic registration of the data in the platform until the patient gets negative for the viral load. If he has hepatitis B, he's also being treated, and we follow up the patient in the platform with the registration of the viral load. So through this process, we are able to have a registry of all eligible patients for treatment. We have the possibility of having a data mining tool, which we have the screening criteria of the numbers of dropouts during testing, the compliance, the outcome. And this gives us information for key policies and decision teams in the future, because we have to realize that one thing is to start the process, another the policies that will come in the follow-up of these patients. It also allows us to have the evaluation of the treatment effectiveness of the process. And also it allows us to identify barriers and facilitation processes to engage the general practitioners with the direct antiviral agents. We have a referral system in place for the national healthcare services. So if the patient migrates from the place where he was attended, he will still be able to follow up his treatment. And with all of this, we want to foster the publication of consistent data, which will surely help us to follow up and monitor with the aim that we have to eliminate hepatitis C by 2030 in the country. So let me show you some of the results up to now. This is the slide which I showed you up to 2018, which included several years, and in which treatment was initiated only in approximately 6,000 patients. I do not have the full data until the end of the year, but I can show you some of the data of the federal health system, which takes care of 50% of the attended population. The other 50% is covered by the social security systems of the country. And you can see here that in this year, we have approximately done 138,000 point of care testing. We have obtained positive results of viral load in approximately 5.89% of them. And we have initiated treatment in approximately 8,143 patients. We will have the result at the end of the year of the whole system. But as you can see, in 1 year, we were able to treat more patients than those that were treated up to 2018. And also, we have this year the problem of the pandemic, but hopefully we will have getting close to the 20,000 patients. But we hope that next year we will be able to identify the 40,000 patients that is the purpose of our study. So in my final slide, I would like to mention that some of the lessons that we have learned is the importance of the screening and early detection of patients, because this will facilitate the road to the hepatitis C elimination by 2030. The model of care was transformed, it was simplified, and we have integrated the model with the participation of the different stakeholders. I would also like to leave as a message that it is necessary to migrate, not only from a treatment strategy to go to an elimination strategy in which the screening, the sampling of the patients is very important to detect them before they go on to develop the complications of chronic liver disease. I appreciate very much your attention. Thank you very much.